Hi, my name is Gabriela Espiazu and I'm going to talk about oligodendroglioma. Oligodendrogliomas are a type of glioma that starts in glial cells called oligodendrocytes. All oligodendrogliomas have a chromosome abnormality where the P arm of the chromosome 1 and the Q arm of the chromosome 19 have been deleted. Oligodendroglioma sometimes spread through the cerebrospinal fluid, but rarely it spreads outside the brain or spinal cord.
Welcome to USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition. Page 447. What is oligodendroglioma? Oligodendroglioma is a relatively rare, slow-growing tumor that most often occurs in the frontal lobe. What is the term used to describe the capillary patterns in oligodendroglioma? The term used to describe the capillary pattern is called the chicken wire capillary pattern. What is the classic term used to describe oligodendrocytes and why? The term used to describe oligodendrocytes is the fried egg cells, and the reason for this is because they have round nuclei with clear cytoplasm. What happens to oligodendrocytes and oligodendroglioma? In oligodendrogliomas, the oligodendrocytes are usually calcified. For more information on this topic, click on the link in the description section below. For a full USMLE Step 1 review, be sure to
other common type of glial cell which gives rise to tumor is the oligodendrocyte, which, as you know, is the primary myelinating cell of the central nervous system. This is an oligodendroglioma. Notice that we have a normal gyral and sulcal pattern here throughout the cortex. This looks like a corpus callosum, but in this area, certainly here and possibly a little bit off to the side here, but certainly this looks like a cut section of something very irregular. Let's take a look microscopically. If you have ever seen oligodendrocytes normally, and I wish we had a picture here, they generally look very much like this. They have a central nucleus, and they have an abundant amount of washed out cytoplasm because that's their myelin, that's their insulation, that's fat, so that's why it washes out. In fact, if you were to just take this area here as a square and say this is from the brain, what type of glial cells would they be? Most people would say they look like oligodendrocytes. This is a classical appearance. But please note, these are widespread clonal proliferations of oligodendrocytes. Sure, you can see blood vessels here, and here, and here, and here, and here, and nice little stacking of red cells inside here and here. But all of these cells that have this little clear space around the nucleus are oligodendrocytes, and they are basically all the cells in the field. In addition, oligodendrocytes often can have these little areas of calcification as well. They tend to calcify a lot in this little stippled sand-like fashion. Notice that these are true dense calcium bodies, which is why they tend to fracture when you do the processing. They are not like the psammoma bodies that we see with meningiomas. These are true calcified bodies. This is oligodendroglioma. Thank you very much.
The classification. Based on the World Health Organization grading system, oligodendrogliomas are classified as low grade, grade 2, and high grade, grade 3.
The pathology of oligodendroglioma is unique, but the grade is also unique and very important. And on this slide, on the far left, as you're looking at it, that's the low-grade tumor. The middle is kind of halfway between a high-grade tumor and a low-grade tumor. So you can see on the far right, that's a much more aggressive high-grade, what we call an anaplastic oligodendroglioma or a grade 3 oligodendroglioma. The reason I put the picture in the middle there is to show you that it really is sort of a transition and it's a continuum. So you could have, and this is very important, you can have a tumor where, say you have a tumor that your doctor can only take a biopsy from, or only part of it is able to be removed. You can have pathology like on the far left or the middle in the piece that you're looking at under the microscope, but in the middle of the tumor, it might look more like this on the far right. So it'll end up behaving more like that on the far right. So you may hear me today and your doctors talk about something called sampling error. It's not really an error. It's just that if you take a biopsy of an area that looks like this, the path report might say grade 2. But yet your doctor may be talking to you as though you probably have a higher grade tumor, and that may be because of the way your scans look and the way that they may feel and suspect that other areas of your tumor look more like the two pictures on the right. So that's really more a sampling issue than an error, but that's a very
Low-grade oligodendrogliomas. Low-grade oligodendrogliomas are grade 2 tumors. They are slow-growing and may be presented for many years before they are diagnosed. These tumors can become more aggressive over time. People with oligodendrogliomas may have a long history of seizures.
Gliomas are a heterogeneous group of tumors that arise from the glia, the supporting cells of the central nervous system. Astrocytoma, oligodendroglioma, and oligoastrocytoma are grade 2 gliomas that account for up to 10% of all primary brain tumors in adults. Morbidity and mortality are significant. A study with a median follow-up of nearly 6 years demonstrated that the addition of combination chemotherapy to radiation at the time of initial diagnosis results in significantly longer progression-free survival than radiation alone, but not significantly longer overall survival. Follow-up in that study has now reached a median of 12 years. The authors have assessed 251 eligible patients who were randomized to radiation therapy alone or radiation therapy followed by 6 cycles of procarbazine, lomustine, and vincristine. After 12 years of follow-up, 55% of the patients had died. As in the earlier results, patients who received combination chemotherapy had longer progression-free survival than those who received radiation alone. Both the 5-year and the 10-year rates of progression-free survival were higher for those who received combination chemotherapy. But in contrast to the earlier results, the current results with longer follow-up show that patients who received combination chemotherapy also had significantly longer overall survival than those treated with radiation alone. The 5-year and 10-year rates of overall survival were significantly higher in those who received combination chemotherapy. Thus, patients with grade 2 glioma who received radiation therapy followed by 6 cycles of combination chemotherapy lived significantly longer than those who received radiation therapy alone. Full study results are available at nejm.org.
Anaplastic oligodendrogliomas. Anaplastic oligodendrogliomas are high-grade tumors. Anaplastic oligodendrogliomas usually grow quickly. Tumors may develop in one place or in many places throughout the brain. Treatments. Individualized treatment of an oligodendroglioma depending on the presence or absence of symptoms, location, and biological aggressiveness of the tumor, extent of possible surgical resection and histopathology, and degree of aplasia. Treatment depends on the type of oligodendroglioma.
So there's lots of different treatment options, though. There's watchful waiting, meaning you don't do anything but watch very carefully with serial MRI scans, and we defer treatment until, say, the tumor progresses in size or grade or symptomatically in some way. And that may be appropriate for some low-grade tumors, but not surgery with a caveat, and the caveat's important, if it's technically feasible with the goal of preservation of neurological function and an acceptable level of risk. You can have radiation therapy, you can have chemotherapy. The benefits of treatment, of course, should always outweigh the risks of treatment, and the risks of not treating also have to be considered in patients that you're considering watching. So surgery, if we talk about resection, what do you get from it? Well, you get a verification of the diagnosis, and you get more tissue from a resection than you do a small biopsy, so the grading may be more accurate. There's a relief of signs and symptoms in some patients who have very large tumors where there's swelling and what's called mass effect. You get basically rid of those cells. That's what cytoreduction means. It means reducing the cell number. And in some patients, if you can do a large enough resection, that might improve outcomes. It allows for a lower steroid dose. As many of you know, steroids are used to control swelling and edema, and they have their own set of side effects. So usually if you have less mass effect and a smaller tumor burden, in a sense, you can get away with either no steroids or a lower dose. We already talked about reducing sampling errors because you get a bigger piece of tissue. So it should be done if it's technically feasible with the goal of preservation of function, and as long as there's an acceptable level of risk. The extent of resection, if it's large enough, is an independent variable associated with a longer survival. So that means if you can get what we call a gross total resection, which is everything that we can see on the MRI scan is gone, or very close to it, like 80 to 90% of what we can see, or maybe slightly less than that, you will likely have an improved overall survival. But that shouldn't be done with the cost of, say, some serious neurological deficit happening. You know, if we hurt you more than we help you with the surgery, then it's not really necessarily a good thing. Some patients can even benefit from reoperation at the time of tumor recurrence.
Benefits. A clinical trial has shown that addition of chemotherapy to radiation therapy leads to a near doubling of median survival time in patients with a form of brain tumor, oligodendrogliomas, that carries a chromosomal abnormality called the 1p19q co-deletion. Disadvantages. There may be fewer clinical trials for rare types of cancer than for more common types. It is hard to organize and run trials for rare cancers. Getting enough patients is critical to the success of the trial. The results won't be strong enough to prove that one type of treatment is better than other if the trial is too small. Issues applied in Ecuador. A study made in Eugenio Espejo Hospital by the Dr. Maleno Ortiz and Dr. Maritza Quispe, in which of the 126 cases of neuropathology, 21 cases, 16.6%, were of oligodendrogliomas, being more common in women than in men between the ages of 30 to 40 years old. 13 cases, 61.9%, were low-grade oligodendrogliomas. On the other hand, 8 cases, 38.9%, were anaplastic oligodendroglioma. Conclusion. Oligodendrogliomas are glial brain tumors that are divided into grade 2 and anaplastic grade 3 tumors. Typically, they have an indolent course, and patients may survive for years after symptoms onset. Both types of tumors can be treated with similar treatments. The incidence of this brain tumor is in our country and worldwide is low, yet nowadays more studies are being made to have an early diagnostic so it can be controlled on time. Thank you.